So I'm very pleased to introduce our first speaker, Dr. Peter Mollee. He practices as a consultant haematologist at the PA and heads the myeloma and amyloidosis service at the PA Hospital in Brisbane. He's very distinguished, runs one of the few clinics in Australia dedicated exclusively to the care of patients with myeloma and amyloid. So, you're welcome here.
Thanks very much. I should check, is my microphone working? Good. Thank you, Dave. So I've been asked to talk about myeloma and the immune system. It's actually, I think, a very difficult talk to give because the concepts in the immune system are very complicated. I don't understand half of them. So I'm going to have a go at it, and hopefully I'll be able to convey something useful to you. I have to say thanks very much. You won't be able to see down the back there, but Dr. Hang Kwok, I was a little bit viral on the weekend, which is my normal talk preparation time, and I didn't feel like making a whole talk. Unfortunately, Hang, who's giving the same talk in South Australia at the moment, lent me some of her slides. So a lot of these are from her, so I really have to acknowledge her help with this talk. So I'm going to first try and talk a little bit about what the immune system is, what makes it up, and then a little bit about how myeloma interacts with the immune system and how the immune system interacts with myeloma, and then talk really about the consequences of that is. That is, in myeloma, what happens to the immune system. It's depressed, you're easy to get infections and things. And then finally on how, in fact, we can harness the immune system to attack myeloma. But after about 3 decades of, I wouldn't say fruitless, but a lot of research which didn't have a lot of impact clinically, just in the last 5 years there's been a lot of progress in this area, not just in myeloma but in all cancers. So, firstly, back to school. Or for those who didn't do biology at school, this will be a first time learning experience. So here's this guy, Paul Ehrlich. He was very interesting guy back in the turn of the previous century. He's the first guy that used antibiotics successfully. It was to treat syphilis, and in fact that's where the word chemotherapy comes from. He named it. He discovered how to make anti-serum to tetanus. He's the guy that worked out how we can find organisms and view all types of blood under the microscope. He developed the stains that enable, so, you know, German physician, hematologist, immunologist, microbiologist, did it all back then. But he back then postulated, it was known the immune system was important in defense against infection, but he in fact postulated that it could be important in treatment of cancer. And he had none of the tools we have these days, but I'll come back to him a little bit later on. He recognised the immune system, not just infection, but maybe involved in tumours. So what is the immune system? It's the body's defence against a variety of things. It's important against disease-causing organisms, so infections like bacteria and viruses. It's involved in the body's defence against malfunctioning cells, for example, infected cells or cancer cells. It's important in keeping control of. And it's involved in other foreign particles, so pollen, you know, which can be annoying. Get a splinter in your foot, your immune system leads into action to try and get rid of that. It does a whole variety of different things. And there's 2 arms of the immune system. There's first what you call the innate system, immune system. Innate means it's just there naturally. It's like shoot first, ask questions later. It just gets in there. If something looks foreign, it just tries and attack it, no matter pretty much what it looks like. The adaptive immune system is a secondary line of defense if that first attack sequence doesn't work, and that's got specific targets. So the adaptive immune system will only attack something that's got a very specific marker on it. It won't just sort of kill anything foreign. So this is the first immune system, innate system. It's got a variety of different things. That's a high-power view of skin cells. So your skin is part of your innate immune system. It's a barrier, stops bugs getting into the body. Obviously, you know, that's an issue for patients with cancer. We stick drips and lines in them. You puncture the skin. That's, you know, one defect in your innate immune system. And it's got a variety of cells that live particularly in the skin, in the gut, in the airways, where bugs get in first, that are just sitting there waiting to attack certain things to keep them out of the bloodstream or lodging and causing infection. Then there's the second part, the adaptive immune system, which is mostly these two types of cells: B cells, which make antibodies, and T cells that directly kill bugs that get into cells in the body. So it's called upon when bugs evade the innate immune system, and it has a specific target that it's dedicated against. So it'll dedicate, for example, against something on the flu virus. It'll just go right against it. And that's why vaccination works. It's an attempt to tell your B cells to make antibodies against a specific sort of bug. And that's why the flu vaccine will only work against the strains of the flu that they are predicting is going to be in the community this year. It doesn't go against all strains of the flu, just against ones they're guessing as being likely. And that's because the immune response that you elicit is very targeted. It's not general across the board. So they're the two arms. So to talk a little bit about how that second arm works, the first one we'll talk about is these T cells. So here you've got a bug, something foreign, it's nasty. What happens if you've got these specialized cell type, doesn't matter too much about the wording, but it's just the principle. The specialized cell type is, again, typically rich in the gut and the skin or wherever. It sees that infecting thing, tries to eat it up a little bit and chomp it into little bits, and then gets one little bit of it to present to a T cell and says to the T cell, we're being invaded, here's a little bit of what's invading us, go to work. So the T cell replicates the one that matches this one, and then it produces a variety of chemicals, they're called granzyme and perforins, which attack the infecting cell and kill it. But it'll only release those chemicals if it meets the target that it's been primed to attack. It won't just do it for anything. So there's two types of these T cells. In fact, there's these cytotoxic T cells. These are ones that do the damage. They're the killer cells. They kill cancer cells, cells infected with viruses, damaged cells. And then there's another type of cell, it's not illustrated here, but it's called a helper cell. And it provides a little bit of positive feedback to get these ones ramped up. And it also helps your B cells make antibody. So they're all related. The B cells are the one that produce antibodies. So this is a schematic of an antibody. And for those of you who have looked at your myeloma protein or read anything in detail about it, it's got this structure as well. So it consists of two heavy chains joined to two light chains. This is the end that can have millions of different possible things, so that it can target a whole heap of different bugs or bits of bugs or whatever. So this is a bit that binds to the antigen or the bit you want to get rid of, for example, on an infection, a bacteria or something. And this is the end down here that tells the immune system, attack what I've bound onto. So the plasma cells come from B cells, and the plasma cells are the professional cells specialized in producing antibodies. So here you've got the bug. The T cell has been told to help the B cell make antibodies specifically against that bug. Those B cells proliferate and produce the plasma cells. The plasma cells then make bucket loads of this antibody. And then that antibody can attach onto the bug, and that alerts your immune system, here's something, it's got an antibody on it, that's not good, you got to eat it. It can also, these B cells, they've also got another system. Instead of differentiating, they can develop in what they call long-lived memory B cells. That is, cells that just sit around quietly. They remember that in the past you've had an infection, you've had to make this antibody. And the advantage of these is that if the system's stimulated again with the same bug, these can ramp up really quickly. Whereas this process takes a little while. So it's a way that your immune system remembers. This is why if you've had chickenpox as a child, very uncommon for you to get it again, that sort of thing. So if you had an infection before, you've got some defense against it. So what about antibodies in cancer? So normally this is what you'd like to happen. B cells make antibody that would fight cancer sort of target. And what can happen once that antibody is bound onto the cancer is there's a variety of ways your body can get rid of that. So once the antibody's on here, there are some times of antibodies once it just by binding can kill cells, but typically it tags it so that then one of these other cells of the immune system can recognize and get rid of it. And this could be what's called a macrophage. That's like the Pac-Man type cell of the body, just chomps up things. It can be these things called natural killer cells. Just by its name you can see they're involved in killing things, and it recognizes the end of this antibody. Or it can be this other system, which is soluble factors floating around in the blood, that if an antibody binds, they'll then come and punch holes in the infected cell and can't live with holes in it. So there's a variety of ways in which the antibody tells your immune system get rid of this thing. So here we are in summary of the immune system. So some microbe, infection, abnormal cancer cell or something is taken up by these antigen presenting cells. It breaks it down into little pieces and then says to your T cells, here's this little piece, make an immune response against it. So the T cell can rev up these cytotoxic T cells, they're the ones that do the killing, or rev up the B cells to make antibody. So that's the normal sort of functioning system. So how does myeloma affect the immune system? So this is what you'd like to happen. You'd like, here's some tumour cells. These could be myeloma cells. The immune system eats a little bit of that and finds some piece of it that the immune system could attack and says to the T cell, get an immune response against it. You get a T cell developing out of that that's good at attacking just a cancer cell that expresses that bit, and so it attacks it. What happens, however, in cancer is that the cancer cells can secrete a number of factors that stop that process, and so instead of getting an attacking T cell developing out of it, you get a T cell that is defensive against that tells your immune system don't attack this cancer. So the cancer cell itself can influence the immune system to not work normally. And as a consequence of that, you don't get these cells developing that kill the cancer. This is just one mechanism. There's a variety of mechanisms that exist. So that happens in all types of cancers. It's further complicated in myeloma because myeloma is a cancer of the plasma cell. The plasma cell is part of the immune system. It's the normal antibody producing cell. So the system gets a little bit messed up more. So normally you'd like plasma cells to make antibodies to get your cancer. In myeloma, all of these cells develop from the plasma cell, but they're defective, they're cancerous. They're the same, they originate from one type of plasma cell, and as a consequence, these cancer cells make bucket loads of just one type of antibody. But that antibody is not particularly good against anything, but this is what we measure myeloma by. So you might have heard, use your myeloma protein, your monoclonal protein, your paraprotein. These are all words for, in fact, a single antibody that that plasma cell that has become cancerous is producing. And what happens with when the malignant plasma cell develops, it affects every cell in your immune system. And this is one of the reasons why patients with myeloma, compared to many other cancers, have particular problems with the immune system not functioning well and a predisposition to infection. It reduces the number of your normal B cells and stops their ability to make antibody normally. It interferes with the ability of the cells that first chop up the cancer cell into pieces and presents them to the other immune system. It stops these T cells working properly, reduces some of their numbers and impairs their ability to make the cytotoxic or the killing T cell, and affects these NK cells so that the NK cell can't attack them. So whichever arm of the immune system you look at, it's impaired in myeloma because the myeloma affects all of them. So why do patients with myeloma get recurrent infections? So here's what should happen. Your bug eaten by the antigen presenting cell, goes to the T cell, tells the B cell to make antibodies. And then the plasma cell will make antibody. What happens in myeloma is you're full of a plasma cell that's become cancerous, and the process of developing normal plasma cells or normal antibodies is impaired. So people with myeloma have reduced numbers of normal antibodies. There's a medical word for that, hypogammaglobulinemia. Some of you may have that. So you can't make the numbers of antibodies that you need to fight off infections. Your B cells don't mature normally, so you can't make the antibody, get the stimulus to make the antibody in the first place. Your T cells don't work properly, so you can't get this pathway and these antigen present. So every part of the pathway that normally is involved in generating a good immune response against infection is defective to some degree. And some patients this is a big problem, some patients a small problem, but everyone with myeloma has it to some degree. So why do you get recurrent infections? In fact, there's a lot of reasons besides the immune system not working well. There's all the things that myeloma causes or that we use to treat myeloma that cause trouble. So dexamethasone or steroids like prednisone. Any of you have been on it for a long time will know that it causes some thinning of the skin. That's an important defense against infection. So it's easy for the skin to tear or get abrasions. It suppresses the activity of pretty much every cell in the immune system. The phagocytes, that's the Pac-Man type cells, the T and the B cells, they're all affected by dexamethasone. It reduces the activity. Now obviously on the counterpoint of that, dexamethasone is great at killing myeloma cells, so it's always a balance, but it does cause trouble. Chemotherapy suppresses the bone marrow function, reduces the production, the amounts of white blood cells, and also reduces their function. Renal impairment is common in myeloma, and the kidneys are very important to the maintenance of a normal immune system. Plus infection leads to dehydration, I've missed a H out, which leads to more renal impairment, so you can get in a cycle easily with infection in myeloma because of kidney problems. Bone pain is an issue, particularly if it's in the chest or at the back, because if it's in the chest or the back, you can't cough properly. You don't clear the secretions normally, and so another reason why infections are a problem. So what can you do about it? Obviously you can optimise your general health, nutrition and exercise. It's very important. You know, it's not good for patients with myeloma to sit around all day. You've got to keep moving to whatever extent you can. It's important to keep the skin intact. Good not to have dry skin, keep it moist. Appropriate footwear. You know, you have to live your life still. So, you know, if you love fishing, you know, go and fish, and you know you're going to get a hook in you every now and again. You got to have balance in these things. You don't want to put yourself in a bubble. Breathing exercises, particularly if you've got, as I said, any chest pain. Reduce exposure to bugs in the first place. These are just common sense things. Hand washing, good personal hygiene. You know, hygiene when you're preparing food. You know, reheat food if it's been sitting around for ages. Avoid direct contact with people with active infections. Now, to some degree, if your family's got an infection, you can't avoid it. But, you know, if someone's coming to visit and they've got a cold, just tell them to come when they're better. So, particularly if you're on, you know, if you're on treatment at the time, it's particularly important. Early presentation to your doctor if you've got an infection. This is important. If I get a flu-y thing and fever, I'm not going to go to the doctor. You know, I'm just going to wait it out, go into my man flu mode, lie down, groan a little bit for the wife's benefit. But if you've got myeloma, you can't do that. You know, you have to get promptly to your doctor, because as opposed to the general community where you like to restrict antibiotics, because in fact everything's normally a virus, it's very easy for patients with myeloma, because of their defective immune system, to develop bacterial infections. So the threshold for antibiotics is much lower in someone that's got myeloma compared to someone that doesn't. There are other things. Sometimes patients have very low levels of antibodies, this hypogammaglobulinemia, and if you're getting recurrent infections with bacteria, not viruses, but bacteria, then sometimes these monthly infusions of immunoglobulins, known as IVIG or Intragam, there's a variety of them, but they're pooled antibodies from the general population, so you're getting someone else's antibodies to supplement your low levels, reduces the risk of infection. Vaccinations are important. The flu vaccine, pneumococcal vaccine, probably important. That's probably only every 5 years. Patients that have stem cell transplant have got a more complicated revaccination program they have to follow because it affects a lot of immunity against vaccinations. The problem with myeloma is not that it's generally dangerous to have the vaccinations or there's more side effects. In fact, there's probably less. The problem is that the vaccinations don't work as well. So whereas the flu vaccination might protect 80% of the population or something, and we don't actually know with myeloma, but it's lost less. It's probably 30 to 50%. So it gives a smaller amount of protection, but that's still worthwhile. And then often when you're on treatment for, with various types of chemotherapy, you might be on what we call prophylactic antibiotics, antibiotics to try and prevent certain infections. And some of you may have been on Bactrim to prevent against a rare form of pneumonia called pneumocystis. If anyone's been on bortezomib or Velcade, you have to be on an antibiotic to prevent shingles, because that's a particular virus that causes problems with those drugs. Any questions for me about infections and things before I go on to talk a little bit about treatments in the immune system? Yeah.
Is there any difference if you're in full remission with your immune system?
The immune system is better if you're in full remission, yes. Yeah.
Is there a vaccination available for shingles yet here?
No.
Because I know there is in England.
There is a live vaccine available, which is what kids can get, or it's called an attenuated vaccine. But that type of vaccine, it's slightly dangerous to give with someone with myeloma because it could cause the actual infection. Whereas if you've got a normal immune system, so all the shingles or chickenpox vaccine is pretty common in kids. A good proportion of the population gets from it. There is a dead vaccine for shingles at the moment. It's not available. There's a couple of trials that have just been completed. We'll see whether it actually works or not, because it's not. There are some viruses where the dead vaccine is not as effective as what they call attenuated or a slightly live vaccine. There's not one available at the moment anyway. Yeah.
Should somebody with myeloma get flu vaccines more often? For example, my wife has actually had one this year. Would it be worthwhile getting another one? Given the fact that
no, we don't advise getting two, but having said that, we don't know. Two probably would be better than one, but we don't actually know. So, and it's often better not to have a second follow-up vaccine straight after the other. So, there's a lot about myeloma and vaccination that we don't know. It hasn't in fact been well studied. So what we do know is the vaccines don't work as well in patients with myeloma. But the problem is the vaccines are constantly changing. Even the pneumococcal vaccine, changes every few years. It's much better now. And so the ones that were studied 5, 10, 15 years ago, that data's out of date. And people don't always keep doing the studies to know how good the vaccines are. But I think as a generalisation, you could say it's not going to provide the same degree of protection as it would someone with a normal immune system. That's not a reason not to have it, I don't think, but I think it's to acknowledge that it's not going to provide as good a protection.
Wouldn't your immune system and its antibodies be trying to fight against the flu vaccine, etc., because it's
no, it's not. No, they don't fight against it. It's just that it doesn't respond as well to it. So you try and stimulate it, and instead of, say, a normal person's is 100%, I don't know what the figure would be, but maybe in the myeloma patient they can only respond 30% as well. So when you look at what there are studies, if you really want to find out, it's very expensive, it's about $150 a test, but you can test to a vaccine whether you generate the immune response. It's only done in research lab type settings, but we know that the percentage of patients with myeloma that you can test their blood 6-8 weeks later and see whether you've got protection against that virus, it is less if you've got myeloma. But does it actively fight it? No. Vaccination is actively fighting the vaccine. That's why you give a bit of a virus or a bacteria to try and get the myeloma system to attack that, to trick the immune system into thinking that it's just had a bit of infection stuck into it. That's, yeah. All right, so how can the immune system be manipulated to fight cancer? So, for a long time, the only real evidence that we had that myeloma was susceptible to attack from the immune system came from allogeneic bone marrow transplants. This is where you have a transplant from someone else, not using your own stem cells, but someone else. It tends not to be used very much in myeloma, mostly because the results of the trials are not good. But what we did see was that patients had a demonstrable, what they call graft versus myeloma effect. So the transplanted bone marrow graft had immune cells in it that could attack the myeloma cells in the patient. And plus, you could give these things called donor lymphocyte infusions. If someone, after their transplant, their myeloma was coming back, you could get T cells, remember the cells that do the attacking from the immune system, from the donor, you know, that gave the transplant, and give them to someone whose myeloma was coming back, and you could see the myeloma come down. And the only reason that would work is if those T cells were attacking the myeloma. So in terms of a proof of principle, it's been known about for a while, but a variety of attempts, as I said, for 30 years to try and produce that immune effect hadn't worked. So here's what we want to happen. We want the offending tumour cell to be recognised by the body's antigen presenting cells, stimulate the T cells, stimulate the B cells to make antibody. So the two parts of this that I'm going to focus on that have been used in therapy relate firstly to the T cells. How can you make T cells attack myeloma? And secondly, how can you use antibodies to attack myeloma? So first, the T cells. So the problem in myeloma is that this process here of getting from a tumour cell to an effective T cell that can attack it is dysfunctional. The antigen presenting cell doesn't work well, the T cells are the wrong type. So there's a couple of ways that this happens. Just as a generalization, there is this group of drugs called immunomodulatory drugs, of which thalidomide, lenalidomide, pomalidomide are in this family, and they're called immunomodulatory because one of their actions is that it's got effects on the immune system. And in fact, they all stop factors that the myeloma cell makes and that the cells where the myeloma lives makes, which in fact upregulates or makes more effective this generation of the immune response. So lenalidomide itself in particular can make these NK cells more active, can increase the production of the right type of T cell. So to some extent that as a drug has got some very positive effects on the immune system. But probably, you know, its major effect is in fact direct killing of the myeloma cancer cell rather than these immune effects. But nonetheless, it's a useful extra additional effect, if you like, that the drugs have. And that all these different types of cells that lenalidomide enhances the activity of a little bit can attack the myeloma cell. So these T cells, so the first thing I'll talk about is these, they're called CAR T cells. Whole heap of words there that are difficult to understand. Chimeric Antigen Receptors containing T cells. So this is a recent development used in a variety of cancers. First started in hematologic cancers, particularly acute leukemia. But there's been some work in myeloma. So normally, if you remember, the T cell, in order to generate an active killing T cell, you have to have this antigen presenting cell recognizing a piece of the myeloma cell to tell the T cell to attack it, and that doesn't work well in myeloma. In chimeric antigen receptor cells, or CAR T cells, what happens is that you've got the T cell, which has got this receptor on it that targets it to the myeloma cell, but you put a bit of an actual target of the myeloma cell into the T cell. So you get, this happens outside the body, so you get someone's T cells, you tell the T cells, or you in fact give the T cell, the little bit that recognises the myeloma cell, you grow them up in the laboratory, and then you give them back to someone. And what happens then is you take away the need for this middleman. So your T cell now can directly attack the myeloma cell. It's got things around it that tell it this is your target. So you've manufactured this cell, if you like, to attack the myeloma cell. So the first human trial was presented in the American Society of Hematology meeting December last year. So fairly new, and people were excited about the results because responses were seen. So this is what happened. Patients with advanced myeloma had to have at least 3 previous treatments and no good treatment available. Got a small dose of chemotherapy. This is necessary so that these T cells that you put in are not rejected immediately by the body. And then these CAR T cells were given. They were, the bit that they'd put in them was part of the surface of myeloma cells, a molecule called BCMA. So this is what the cells are directed against. And there's very little BCMA expressed in any other part of the body besides on myeloma cells, because you don't want these cells attacking your heart or your kidneys or other parts of you normally. And this generated a lot of excitement, but I just, as a cautionary note, I will remind you that just because something works in an early trial, it doesn't always mean it's the bee's knees. You hear about breakthroughs in cancer every day in the media. This one, for example, they presented 12 patients, and the ones highlighted in red are the ones where there was some response, partial response. But look here, it lasted for 2 weeks. I'd say that's a useless treatment if it lasts for 2 weeks, but nonetheless, I'm going to present a bit of data about these 2 down here that had a very good response that was a little bit longer. But bear in mind, this is 12 and 6 weeks data. So this is, 1.5 to 3 months. This is not what we need for myeloma breakthrough. So yes, it's exciting, but is it, it might turn out to be the bee's knees, but it may not be. You've got to realise the other 9 patients didn't respond at all. So here's this patient 10, he had 3 different lines of treatment, really nasty myeloma. So only 3 months after his transplant, he had 90% of his bone marrow replaced by myeloma. So very aggressive, nasty disease. And I'll just focus on this one on the right. This is a graph of his myeloma protein. You say day 0, he got these cells here, the myeloma protein comes right down, completely vanishes. His myeloma's gone into a complete remission. So no doubt that is the response you want. Also got very sick. I won't go into this, but there's a particular problem where you give these cells where you induce an intense inflammatory syndrome. This patient had 5 different types of treatment for his myeloma before he came on. And again, you can see this is the protein, the myeloma protein responding, this time over about 3 weeks, but a very good response, and that's been out to 3 months so far. Just to illustrate that graphically, just take it that purple or pink is picking up myeloma cells in the bone marrow, and here it is 4 weeks and 8 weeks later, it's just, there's no myeloma there left anymore. So certainly it can clear these treatments. There is no doubt that in the patients that they work in, it can clear a lot of myeloma cells. How long it lasts for, whether the side effects are worse, that we'll have to wait and see. But anyway, it does show in principle that this treatment can work. Doesn't seem to cause direct organ damage, but does cause this very nasty inflammatory syndrome that you can get very unwell with. Anyway, they conclude that it represents a promising new treatment for myeloma, and we'll hear a lot more about this over the next 5 years, I think. The second type of T cell I want to call about is called a BiTE cell. So, bispecific T cell engager, a BiTE. So what this is that you get 2 antibodies and you join them together. So what you do, for example, imagine this is a myeloma cell and you've got an antibody that would normally attack it. And then you've got an antibody that can bind to a T cell. So wouldn't it be good, in order to get this cell next to this one, to take this bit that binds to a T cell and this bit that binds to a tumour cell and join them together? So that's what they've done to form a so-called BiTE antibody. So you've got this bit attacking the cancer, this bit bringing the T cell right next to each other, so the T cell can then do it. So that's what happens. You get these things that bring a T cell right next to a tumour cell and tell the T cell kill what it's bound to. So as of yet, we haven't got any clinical results, but we know from work in the laboratory that it does physically bring a T cell. Here's a little T cell, here's a myeloma cell, right up next to the cancer cell and kills them in the test tube. There's been a bit of work where a mouse with myeloma has been given these cells and it can cure the mouse's myeloma. So again, no trial results yet, but we'll have them again in the next few years, I think. Another promising approach to bring the T cells that kill cancer right next to the relevant cancer to try and get it working. Okay, so that's a bit about T cells. Next, we're going to talk about how we can harness antibodies to treat myeloma. So one of the problems with myeloma is that instead of the normal numbers of antibodies that you've got, there are reduced numbers. We've talked about that in relation to infection. Plus, the cells that are supposed to kill the myeloma cells in response to that antibody don't work as well as they should. So what's been developed is some antibodies that bind to things that are expressed only on myeloma cells and not on any other cells in the body. And that way, it's like giving a signal for your immune system, particularly these natural killer cells, to come in and attack that cancer cell. And there's a couple of markers on the surface of myeloma cells. One's called CD38 and another's called SLAMF7, that antibodies have been developed against that bind onto these. So two drugs that's been developed in a fairly late stage of clinical trial. One's called Elotuzumab, the other's called Daratumumab. There's a heap of others as well, but these are the ones in the furthest clinical development. Again, both recently approved in the USA. It's been an exciting time in the US with 5 new drugs for myeloma approved in the last year, and 2 of them were these antibodies. They will make their way to Australia, but we've got a health system that demands cost effectiveness. That is, it not only works, but it's not a horrendous price to get that benefit. And so inevitably things take a little bit longer to get here. So this first one, Elotuzumab, it's a very interesting antibody because it binds not only to the myeloma cell, which expresses this SLAMF7 on the myeloma cell, but it also, these NK cells have got this SLAMF7 on it. But when the antibody binds, it doesn't kill that NK cell. It in fact tells that NK cell, get going. It revs it up. So this antibody works by 2 different ways. One, it tells the NK cells to get going and kill something, and it binds to the myeloma cells so that the NK cells are targeted to it. So it's got a dual mechanism of action. In fact, though, it doesn't work very well when you just give it by itself. In fact, it works well when you give it with lenalidomide that's got this, that's one of those other drugs I talked about that's got a slight stimulating effect on these NK cells. And so this large trial was published recently. It's called the ELOQUENT-2 study, where half of the patients got lenalidomide and dexamethasone, or Revlimid and dexamethasone, and the other half got the same drugs plus this antibody given through the drip. This is a survival, what they call a progression-free survival, so how long the myeloma is controlled for. So this is a proportion of patients whose myeloma hasn't come back. This is time. So if you look at any particular point, you can read off. So 24 months, so 2 years, this is patients whose myelomas come back. At 2 years, 27% of patients, so only a quarter that had Revlimid and dexamethasone, remain free of myeloma return, whereas 41% hadn't had myeloma relapse if they got the Elotuzumab as well. So it certainly provided better disease control. So at any particular point, 10 to 15 more patients myeloma remained in remission compared to if they didn't get the antibody. And that, in fact, this is unusual in cancer trials, but also led to patients living longer. So 5 to 10% of patients at any particular time were alive if they got the Elotuzumab. So that's fairly convincing data. Of course, we don't know how much it's going to cost, but it's going to be north of $100,000. You know, how that'll affect work in Australia, where it's got to be used with Lenalidomide, which costs, you know, 50, 60,000, 100,000, depending on what dose you're on as well. How the government's going to cope with two highly expensive drugs making your treatment even more costly. That's a very difficult decision, but nonetheless a drug that's been proven. Daratumumab is a drug against something on the surface of plasma cells called CD38, and opposed to the other antibody, given by itself, it's highly active. One of the most active drugs we've seen in multiple myeloma. And in fact, on the basis of its activity just by itself in patients whom no other treatment would work, in the US they approved it for use in patients whose myeloma has been through a number of treatments. It is being looked at in a clinical trial where patients get the Revlimid and dexamethasone just by itself, and the other group they get the antibody as well. And those results will be presented for the first time later on this year. So we'll know whether the promise of it actually turns out to truly be effective. So, over 100 years ago, Paul Ehrlich conceived that the immune system can protect against tumour development, and it's only taken another 100 years to in fact be able to bring some of that potential forward. There's no doubt the immune system is a very powerful tool to fight against cancer. We've seen that particularly in some of the drugs in melanoma, the disease that everyone with myeloma gets confused with, but the skin cancer problem. Stimulating the immune system in that condition, even if it's spread widely, is highly effective treatment. And in fact, those drugs are so effective they've been approved and funded in Australia. The question though is how to wake that sleeping giant, your immune system, against to fight off myeloma, and there's no doubt, I think, that at last some genuine progress has been made. So thank you. Any questions? Yeah.
I've heard you can't have the same drug twice, so if you've already had Lenalidomide and dexamethasone,
right,
would you be able to have them plus?
Yeah, good question. So at the moment, the government funds Lenalidomide once, and you get one go at it. So, and as you've seen from at least that last trial I presented, it only works if you give it with Lenalidomide, that antibody treatment. So how, and it's not the only drug that's where the trials showing benefit have been in combination with Lenalidomide. So it's the same for a new drug called Carfilzomib that's been used with Lenalidomide. So how is the government going to deal with that? We've got good data now to show that if you use Lenalidomide and Velcade together, that's better than using either drug alone. So how is the government going to deal with that? I don't know. They will, you know, do their economic analyses. They'll try and push the companies to lower their prices. When drugs become generic, that is, they come off patent, it becomes a little bit easier. So Bortezomib or Velcade's off patent in a few years, and then the price will drop astronomically. But Lenalidomide is not off patent for a long time, so there's no cheap drug coming. It's a big problem. It's not just myeloma, it is every cancer. All of these drugs that stimulate the immune system, antibodies, they are all 100,000 plus. So it's going to be, and these drugs, these antibodies, they keep going until your myeloma relapses. So this could be, you know, 5 to 10 years of treatment. So, you know, that could be $1 million worth of treatment. So how are we going to cope with that? Very difficult questions, and I don't have the answer. But, you know, and then the government's got to weigh that up against care of someone with dementia, or care of some small child with a cancer, or rehabilitation after a broken hip. I mean, how do you weigh all those things up? And then they've got to balance health against defence, and, you know, there's only so much money in the Australian economy. It's not a simple question of because it works, everyone should have it. Because you send if you had every drug available, you could use the entire GDP on it. So how are we going to cope? I don't know. Got to make those decisions. Yep.
The other drug you just mentioned, the carfilzomib, which they've just had some successful trials in the US with, in combination with Lenalidomide and dexamethasone. But it apparently also works quite well with pomalidomide and dexamethasone. As a matter of fact, my medical team in discussions with that drug company at the moment, trying to get me on a trial for it. So the option could be that they're out of the same family, lenalidomide, pomalidomide, so they can't go back to lenalidomide, might be able to go up to pomalidomide, again very expensive, with these others as the option.
Yeah. Look, clearly when a drug's not funded on the PBS, there are other ways it can be accessed. So I, for example, would have treated, I think, 12 patients with carfilzomib so far. That's because the company's had a compassionate program where they give it away for free at the moment. They do that when they're coming up to getting funding. They like to get people familiar with the drug, but you know, you got to try and get it while you can. So there are compassionate programs, and there's the same with that Elotuzumab drug. There's a compassionate program for it. There's not for the Daratumumab. And then the other way you can often get them is with clinical trials. So for example, we've had a carfilzomib clinical trial open for a while, and there's another one, in fact there's another 2 coming in Australia. We've got a trial with that Elotuzumab coming in Australia. We've got a trial with pomalidomide and ibrutinib. That's another new agent haven't trucked on. So the other way you can make sure your patients have access to drugs is have access to clinical trials. And there's actually an app now for those of you that have phones called Clinical Trial Refer, which is an easy way to see all the clinical trials that are available in Queensland or indeed Australia on an app, and you can see if there's something that's suitable for you. So there are big centres in Brisbane that, for example, all have clinical trials open in myeloma, and it's a very useful option.
I was just going to ask, originally I had Velcade, which got me through quite quickly in a matter of a couple of months, and then it was stopped. The government said, no more, thank you very much, that's you. But I was under the impression, and I don't know how I got it, I think it's my oncologist told me this, that there was some that had been kept over, as it were. So if necessary, I could go back onto what was left. Would that be feasible or not?
So it'll probably depend how long it's been and whether someone notices. So these drugs are administered under what's called a highly specialised drug program, which is what that really means is a highly expensive drug program. And so what happens is, as opposed to most other drugs where no one's particularly monitoring the usage of these drugs is monitored. So the doctor, has to have a special authority number when they write the script, but then the pharmacy also has to go through a process to dispense that drug as well. Whereas that second step doesn't always happen for most drugs. And so, it's possible, for example, that if someone notices that a script from 2 years ago is attempting to be used, that I think there'd be a high chance that that would be
No,
pulled up.
there were 10 doses left, and I thought, oh, that's good.
Yeah, it depends how much time. You know, I suspect if it's look, I don't know how they actually police them, but I imagine if it's used with a break of only a few months, they wouldn't take any notice, because it's often the case that someone can get unwell and can't have some treatment for a while, and then can be restarted when you recover from illness. So it's all a bit. Velcade's not such a big deal, because if you responded to it before and it works for more than 6 months, you can get it again. So you can in fact have multiple goes at Velcade.
Oh, well, that's probably what
But Lenalidomide at the moment, just one go. I mean, Lenalidomide's about to be approved for initial treatment of patients who are not eligible for a transplant. And that's going to throw the cat in the pigeons, because if you use it up front, then presumably, we still haven't seen the wording, but presumably you're not going to be able to have a second crack at it down the track. So I don't know how that's going to work out.
I just wanted to commend you on your presentation.
Thank you.